Well, hello everyone, and welcome to today's webinar. And thank you for joining us. I'm seeing people trickle in, so we'll give people a minute to start rolling in. Welcome to the webinar. All right, well, I'll go ahead and introduce myself. My name is Srila Sharma, and I'm a professor of epidemiology at the University of Texas School of Public Health. Today's webinar is hosted by the Michael and Susan Dell Center for Healthy Living at the UT Health School of Public Health in Austin. Before we get started, I want to make some housekeeping announcements. This webinar is recorded and will be archived along with the presentation slides on the Michael and Susan Dell Center website at msdcenter.org. And you can see on the slide all of the resources that are available on the website, and there's a QR code on the screen as well to visit the website. If you have any questions during the presentation, please enter them into the questions chat box. We will have time for a Q&A session at the end of the presentation. All right, well, let's go ahead and jump in. I'm excited to introduce our speakers today, myself, and I'm joined by Dr. Nalini Ranjit and Danielle Sanders. Dr. Ranjit is Associate Professor of Health Promotion and Behavioral Sciences at the UT Health School of Public Health Austin campus. And Danielle Sanders is the Food for Change Health Partnerships Manager at the Houston Food Bank. All right, well, we'll go ahead and start. Dr. Ranjit and Danielle, feel free to turn off your cameras whenever you want. So I'm going to go ahead and kick off the webinar. So today we will present on the food prescription program, the Houston Food Bank Experience and Outcomes. And we will be specifically talking about the multidimensional evaluation of the Houston Food Bank food prescription program implementation over a 3-year period. Well, I would be remiss if we were talking about this project without mentioning many of the colleagues and the partnership with the Houston Food Bank, and some of who are in the audience today. This was a partnership between the University of Texas School of Public Health and the Houston Food Bank, and we would also like to acknowledge the Rockefeller Foundation for their funding of the project. The findings and conclusions contained within this project are those of the authors and do not necessarily reflect positions or policies of the Rockefeller Foundation. So let's first level set what is food prescription. The global epidemic of diet-related chronic diseases has really underscored the importance of both adequate and healthy food as a mode of prevention and treatment of diet-related chronic diseases. And what we have particularly seen is that people who are food insecure and lack access to healthy food are especially predisposed to increased risk of several chronic diseases. The other, in the last several years, food as medicine or food prescription programs have gained a lot of popularity in the US as a way of mitigating food insecurity and improving health outcomes in at-risk populations. Now, food prescription programs, there's no set definition for what constitutes as a food prescription program. And they vary in intensity and the type of the program components, from home delivered medically tailored meals all the way to delivery of produce baskets at home, to even vouchers that can be redeemed at select food pantry type locations or even in retail stores. The good news is that there's also concurrently been a lot of research that's going on in this space, and there's strong evidence that specifically for medically tailored meals, that they're effective in reducing healthcare costs, improving health admissions, and length of inpatient stays. However, when some of the other models related to food prescription programs have been challenging in terms of determining their impact because of the heterogeneity in implementation, small sample sizes, and also evaluation plans being of varied nature. There's also been an increased interest because these are programs that are being implemented by healthcare organizations in partnership with social service agencies. There's increased interest in institutionalizing these programs, their scaling, as well as considerations for value-based care reimbursement. So there's a lot of conversation happening in this space as well. Which takes us into the purpose of the study. So the Houston, and Danielle will talk about this in a minute, but the Houston Food Bank Food Prescription Program has been implemented for several years, starting 2015. And the purpose of our study was to conduct a comprehensive evaluation of the functioning, the implementation, the outcomes, and the cost effectiveness of a prescription voucher-based food prescription program implemented at scale by the Houston Food Bank. So our main aims were to examine the clinical, primarily the cardiometabolic outcomes among patients who used the program as compared to those who did not. We also conducted a cost effectiveness analysis to estimate the incremental gains. So we looked at quality adjusted life years with the Houston Food Bank's food prescription implementation as compared to standard medical care. We also assessed and identified the gaps in patient information and data flow, given that there were multiple institutions that were involved in this implementation. And then last but not least, we assessed the perceptions and experiences of the Houston Food Bank Food RX program across the spectrum of healthcare providers, food pantry staff, and the patients who were participating in the program and who enrolled but did not redeem their prescription. So with that, I will hand it over to Danielle to describe the food RX program at the food bank.
All right, thank you. And so just a little bit of background about the Houston Food Bank. We are the largest food bank in the nation by distribution, and our service area actually does extend beyond Houston into 18 of the Southeast counties. So our mission of achieving food for better lives is one way that we do that is through the Food RX program. So like Dr. Sharma said, the purpose of the program is designed to mitigate the effects of food insecurity and help improve health outcomes by delivering nutritious foods to members of the community. So we've got two models of how that actually happens. The first is a community health program. So community members or patients at a certain clinic may enroll in a type of nutrition education program designed to help them manage their chronic condition. So for example, the diabetes prevention program, which runs for about 12 months, as long as they are engaging with that program, patients maintain their eligibility. The other is the most common method, and that is where patients are engaging with a traditional healthcare partner. So for example, Houston Food Bank forms partnerships with clinics across the service area, and we help them integrate a food insecurity screening tool into their process clinic flow. So we use a 2-question hunger vital sign questionnaire to help them assess food insecurity among patients. When they answer yes to one of the 2 questions or both, they're eligible for the program. And so the healthcare provider provides them with this voucher. It's a food insecurity, a Food RX card. So they take that card to the Food for Change market and they're eligible to pick up their prescription. Next slide. Okay. And so with the food prescription, they are allowed to redeem 30 pounds of fresh produce and 4 additional healthy items. And so what that looks like is at least 2 or more variety of fruits and vegetables, and then 4 additional healthy items. And those healthy items may include low-fat dairy, frozen protein, nuts, seeds, legumes, and then whole grains. So it's not meant to be a full plate intervention. We are specifically emphasizing the importance of fruits and vegetables, as we know that those are essential to the prevention of many chronic health conditions. And so again, they're eligible to redeem this twice a month. And then the client choice model that we emphasize at Houston Food Bank Markets are intended to be much like what you and I may experience going to a traditional grocery store. So it's set up very much the same. They grab a basket and they shop. And we hope that this helps maintain a dignified experience and also allow for personalization and then facilitating the consumption of culturally relevant foods, because that's also important. Next slide. Okay, and so just the characteristics of the patients that were enrolled in participating in this study. We had a total of 3,093 patients between May 2018 and March 2021 across a total of 21 of our healthcare partners. So just to describe the average participant, the average age was 49 years old. They identified mostly as female. They were primarily married, and the primary language spoken among more than half of the participants was Spanish. They identified as Hispanic or Latinx and had less than a high school education. Next slide. Okay, and this is just a visual representation of the Food RX program during the study period. We have grown just a little bit since then. So this is a kernel density map. And as you can see, the map shows the locations of Food for Change markets or pantries, and those are designated by the red dots. We also had mobile market trailers or pantries in the light blue dots. And so that was just where we brought out a mobile market where there was not an existing brick and mortar market, and they could also redeem their prescription there. And then the healthcare clinics are the dark blue dots. So as you can see, there is a pretty good overlap between the markets and the healthcare partners. They overlapped pretty nicely. And then you can see by the heat map, the density of where the patients actually reside. So in the dark blue, it's where there are some patients, but it's pretty sparse. And then looking into the red colored areas, that's where patients lived in high density. So while patients may live pretty far away from the clinics or the markets, again, there is good overlap between the markets and the healthcare partners. And then I'm going to turn it over to Dr. Ranjit. Nalini, I believe that you are muted.
I'm sorry. Okay. So our first task was as Sheila mentioned, we had 3 steps to the evaluation. The first was the clinical effectiveness analysis, that is to determine if there were real changes in the outcomes among patients who use this program. The second and third parts of the evaluation will be covered by Sheila. Next slide, please. Yeah, can we go on to the next slide, please? So before I start talking about this, I want to remind you that this program is a relatively light touch program because we give prescriptions to the patients, but patients are free to use them or not use them. This client choice model, and besides, they're also free to decide what they're going to purchase with each purchase. This type of client choice model is very different from the model where food is delivered in baskets, in medically tailored baskets to people's homes. It's light touch because it allows patients choice, but the risk of this model is that people may choose to not redeem their prescriptions at all. So given that background is important to understand the impact analysis. To conduct the impact analysis, we pooled data from the healthcare providers who provided data on all patients that were enrolled into the food prescription program. So they provided any clinical data that was collected at baseline, as well as any follow-up data that they obtained from patients who returned to the clinic. Patients were enrolled if they were food insecure and had an HbA1c of greater than 6.0. I'll add that there were other criteria. If their lipid levels or their blood pressure levels were above clinically risky levels, they were also enrolled. The outcomes measures which were measured for these patients were HbA1c, BMI, systolic and diastolic blood pressure, and LDL levels. Now, not all healthcare partners measured all of these outcomes. So for any given patient, we may or may not have had all of these outcomes. So we decided to only include those patients that had at least two measures, a baseline measure and another measure within 6 months of follow-up. The patients that had only one measure could not be included because we had no idea how their health changed over the course of the program. So this is called a complete case analysis. So in this program, given that patients could choose whether or not to redeem their patients, there was only one way in which we could think about defining exposure. So we defined exposure, exposed patients as those that made at least one visit to a food pantry or a food bank between their first and second outcome measures. Now remember, they're eligible for 12 visits. They're allowed to redeem 2 vouchers a month. So they are eligible for 12 visits in that first 6 months. But we considered anybody who made even one visit to be eligible, to be exposed to the program. So in contrast, the control patients were enrolled patients that did not visit any food bank or pantry between their first and second outcome measures. Remember that these control patients, even though they did not visit any food bank or pantry, they were enrolled in the healthcare system and therefore were receiving standard medical care. And similarly with the exposed patients. So all patients were receiving whatever lifestyle counseling or medication that was provided by the healthcare partner. We used mixed effects regression models to explore the amount of decline in these markers and the odds of a clinically significant decline in some of these markers as a function of exposure. Next slide. Okay. So let's talk about exposure first. So in this period, May 2018 to 2021, we had data from 2,028 patients. When I say we had data on at least 2 measures. So about half of these enrolled patients redeemed a voucher at least once during this period. So in all, 47% of the people who were enrolled chose to not redeem their vouchers. And what about people who redeemed their vouchers? We found that 85% of people who redeemed their vouchers visited a pantry 12 or fewer times. There were a few hyper users who somehow managed to get more than 12 visits within that 6-month period. About 10% of people visited a pantry more than 18 times. Among those that visited, the average number of visits was 7. So they were utilizing roughly half of their what they could claim. What about baseline levels of outcome measures? These are clearly sick people. So you can see here that the HbA1c level at baseline was 8.2 among the control and a little bit higher among 8.5. In fact, this difference was large enough that it was a significant difference. So people who redeemed their vouchers, remember exposed people are people who redeemed their vouchers, had slightly higher HbA1c levels, or they were a little bit sicker. And you can see this across the other markers as well. For BMI, they had a slightly higher BMI. The systolic and the diastolic blood pressures were also a little bit higher. But these are small clinically, they don't mean that much. Next slide, please. Okay, so on to the results from the regression. So we computed the size of the pre-post difference in each of the markers in the control group and the exposed group. Let's look at HbA1c since that was the most interesting result. So people in the control group experienced a decline in HbA1c, a decline of minus 0.24%. But people in the exposed group who got both the medical treatment and the food RX experienced an average of minus 0.52% in HbA1c. This was a statistically highly significant difference. Now you'll see that changes were experienced in each of these markers, but for BMI and LDL, they were not significant. It's worth noting, though, that even though BMI and LDL, there was no significant difference across these two groups, the exposed group actually experienced slightly more favorable changes over the course of the 6 months. Systolic and diastolic blood pressure, again, we saw that the exposed group experienced some declines that were much larger and more favorable than those in the control group. Next slide, please. So the last slide, we looked at the total change among those that were exposed versus those that were not exposed. So we decided to look at this in some other ways. We wanted to see if people who were visiting more frequently, we call this intensity of exposure, were more likely to experience change. And we did find that the intensity also affected the amount of change. So HbA1c, every additional visit per month led to a minus 0.12 decline in HbA1c. Again, we saw, well, in LDL, we did not see the kind of outcome we wanted to see. But in systolic blood pressure, again, we saw that intensity of visits to the pantry or frequency of visits to the pantry led to better changes in BP decline. Next slide, please. And last of all, we conducted a separate analysis to see if what % of people were obtaining a clinically significant decline in HbA1c. Now, a clinically significant decline is defined as a greater than minus 0.5% decline in A1c. And we did this by, we used a dose response type of analysis. We classified the patients as those that had no visits, those that had 1 to 6 visits. So these, you remember that the average number of visits was 7, and those that had 7 or more visits. So the results show a clear dose response effect. You see that for people who had no visits, about 34%, and this was probably due to the medication, experienced a clinically significant decline. Compare this to people who had 7 or more visits to a food market. 50% of these people experience a decline of 0.5% or more. So this is a really impressive result. Also that it confirms that the more visits you make, the more likely you are to experience a clinically significant decline. Next slide, please. Okay, how do we contextualize these estimates? I do want to say here that ours is the first study to report dose response effects. People not visiting the pantry in a prescription program or not visiting a retailer. Can we go back, please? Sheila, I think you lost the slide. Okay, sorry. We are the first ones to show that there is an actual dose response effect. We also are, I believe, the first to show this metric of what is a probability of a clinically significant decline. Now, are these results plausible given the results of other studies? In fact, our estimates are in line with what has been found in other studies. So a recent meta-analysis that came out, I think it was last year, across 14 studies showed an 80% decline, 0.8% decline in HbA1c levels among users of food RX. However, that was across different types of food RX programs, including the more intensive ones. One study that was more comparable to ours in terms of scale was a 3-state study using food banks. but it was a home delivery model where prepackaged boxes of diabetes appropriate foods were distributed once or twice monthly through food pantries to approximately 700 clients. Among patients who had a high HbA1c at baseline, there was a minus 0.48% decline. Ours was minus 0.52. So again, ours is quite comparable to what's been found. Another advantage of our study is that we had a control group. So we could actually compare the changes you would experience if you experienced a food RX program over and above usual and customary treatment. And then another thing that's promising about our results is we did this with actually fairly limited data. Although our numbers were good in terms of sample size, there were a lot more variables that we could potentially collect and utilize to better understand who exactly is benefiting and why they're benefiting. With that, I'll pass it on to Sheila.
Thanks, Nalini. So where do we go next in regards to these findings? So the important, to underscore what Dr. Ranjit just said, the clinical effectiveness analysis confirms some clinical benefit of the food RX, specifically in regards to hemoglobin A1C, but does raise additional questions. And one of the big ones that is probably on most people's mind is the program cost effective? And at this point, we are finishing up the cost effectiveness analysis, but our preliminary analysis where we use quality adjusted life years shows that each additional quality adjusted life year gained with food RX costs about $1,300. And this is highly cost effective, even more so if you compare it to even childhood immunizations, which are considered to be one of the most cost effective type of intervention. Food RX was even more cost effective than childhood immunizations. And a typical willingness to pay threshold for quality adjusted life year is assumed to be $50,000 to $100,000. So at a cost of $1,300, the program is highly cost effective. Now, some of the other questions that we also have been looking to answer with the project is, are there systemic reasons for low utilization? As Dr. Ranjit pointed out, about half of the participants who were enrolled chose not to redeem their voucher. Well, what might be the reason for that? And can perspectives of both implementers and end users provide insights to improve programming and redemption rates? I mean, clearly dosage matters, which means that we need people to engage in the program on a continuous basis for the program to be effective. So answering these questions require cost data, an understanding of the process, the data flow, and the insights into the experiences of the patients and providers, which I will present for the next few minutes. So first, starting with the systems and processes study. So just so that y'all are not dizzy, let's start from the left to the right. So the data flow for the Houston Food Bank Food RX program starts with the healthcare provider and then intersects with the Food for Change market. So the blue boxes that you see on the left are, the patient comes in, gets screened for food insecurity, has labs drawn, anthropometrics that determine ultimately their eligibility for enrollment in Food RX. They get their Food for Change ID card at the healthcare provider, and they get the information regarding the pantries that they can redeem their prescription at. And then on the right-hand side, you have the Food for Change market, where the patient shows up at the first visit, the green boxes that you see there, and they enroll in the program, and that's where their tracking begins at the Food for Change market. Now, what you see in the beige boxes, and unfortunately, we don't have a lot of time today to go into details around this, but overarching, the beige boxes highlight the challenges, particularly in regards to the data processes and quality, and the various systems of record that you see in the gray boxes are below as well. But the main challenges that the main challenges that we identified in the data processes were associated with tracking of the information and also the flow of the information between healthcare agency and the food for change market. And we'll talk about that in a minute. But in looking at these challenges, they also present opportunities for improvement. And so with this particular study, we identified several opportunities which are pretty low cost. The first one being a framework-based approach to implementation and evaluation. A lot of frameworks are out there that are theoretically grounded, evidence-based, called like REAIM, C4, and others that really provide a sort of a benchmark of what are the variables that we want to measure and track, and then start developing the databases around what the framework is guiding. And so that's sort of the first step in regards to the next phase of this work is what is the framework that we want to use. For this particular evaluation, we primarily used a REAIM framework to guide our assessments. The second is the data quality and usability can be improved by standardizing a lot of the process and the content by using, there's a lot of automation with data entry procedures, using online surveys, and using real-time visualization software as well, instead of batch processing of visits, so that any troubleshooting can happen right then and there, rather than wait 6 months down the line to know, which patient came in and which one didn't. So that there's opportunity there for standardizing and automating and using some real-time monitoring software as well. A big sort of a basic infrastructure challenge that exists, that is more of between systems, not within systems, is that at this point, there is no warm referral between healthcare and social service agencies, which means that when a patient is given a prescription at the healthcare agency, until they show up at the Food for Change market, the market doesn't know that the patient is coming or has a referral. And so the burden is really on the patients in regards to showing up. And so how do we establish that warm referral process and also adequate communication channels? Because the burden for the patient to show up at the pantry, at least the first time, lies with the healthcare provider. And the burden of recurring visits does lie with the Food for Change market and the healthcare provider. And so there needs to be an established communication approach to ensure that the patients keep visiting the pantry. Because again, we want to underscore that there is a dose response effect for this type of a program. The last piece of data that we would like to share today is around program perceptions. We actually collected and analyzed data because from healthcare provider, from food pantry staff, as well as the patient, because we wanted a 360 view in regards to contextualizing our quantitative findings. All of the pieces that you saw earlier in regards to redemption rates, as well as informing implementation of the program and the outcomes that we saw. So starting with patients, these are our most important stakeholders, and We'd conducted interviews with patients, and we had two groups, those who were enrolled and redeemed their prescription at the Food for Change market. And the second group was those who enrolled but did not redeem their prescription. So these were our quote unquote control patients. And these were the four main themes that we saw across the two groups. One is that a recognition of the commitment of healthcare agencies and the social service agencies to value-based care through food prescriptions. And you can clearly see from the quote of one of the patients on why they enrolled, because they were unemployed, and also because of poor eating habits, since you can't buy fruits, buy vegetables, or even fruit. So clearly there is a need and there is value seen in healthcare agencies implementing food prescription programs for their patients. There was a perceived need for ongoing outreach and communication from healthcare providers, particularly in regards to reminders for participation in the program. And there was recognition of individual patient challenges for program engagement. Probably the biggest barrier that we saw to engaging in this form of a food prescription model for food insecurity was actually transportation. And you can see that in this particular quote is the challenge to transportation, because the patient has to physically go to the Food for Change market, receive the food, and then carry that food back and have the transportation necessary to carry that food back to their house. The other challenge identified, or the theme that bubbled to the, oh, sorry about that. The other oops, I am not sure what is happening. Let me go back. The last theme was the need for food pantry adjustments and training, because while the patients were receiving the food and were positively responding to the food, they were happy with the food that they were getting, there was little education that was provided in regards to nutrition and using the food that was provided to them. So additional staff training and increased capacity at the Food for Change market may be warranted. The next group of stakeholders were our healthcare providers, and you'll see this common theme actually across all our stakeholders, which is salience of value-based care strategy. Our healthcare providers that we interviewed, these were the ones that were participating in the food prescription programming. There was a strong desire to continue with food prescription programming, and an even stronger desire for sustainability of these efforts through reimbursement of the programs via the payer groups as well. And it was because of the impact that they saw, and you can see that with this particular quote, that food prescription helps participants use their new knowledge about healthy eating by providing them with fruits and vegetables to go home and eat more healthy, but also help to relieve the monetary burden because it encouraged them to try new fruits and vegetables that they would otherwise not be able to afford. So clearly there's a value proposition that healthcare providers felt in regards to participating in FoodRx. And some other common themes you would see here, patient and food pantry barriers to success, including inventory of the produce at the food pantry and minimizing other co-occurring social needs such as transportation. There was also a strong desire for inter-organization care coordination, and how can healthcare organizations make these warm closed loop referrals with social service agencies to increase participation and retention of the patients in Food for Change in food prescription programs. And last but not least, integration of the healthcare of food RX into existing workflows and quality metrics should be planned as part of food RX implementation in the clinic setting as well. And lastly, we gathered similar data from food pantry staff. So we had 100% of the food pantries that were participating. These were our Food for Change markets in the food prescription programs. And we obtained data from these food pantry staff in regards to both barriers, benefits, and then looked at the themes that bubbled to the top. And what's important to know about the food pantry staff is that these are predominantly volunteers and not paid staff that engage in the Food for Change market for implementing food RX. So one important theme that is critical as this program moves forward is that only about half of the responding pantry staff reported providing any form of nutrition education. And also many of them did not perceive nutrition education to be a salient benefit of the program. And so that is definitely a low-hanging fruit, no pun intended, in regards to really bolstering and furthering the impact of food prescription program, that it's not just a handout of food, but that there's a nutrition education concept so that people can convert those food into healthy meals. The pantry staff and volunteers also had a perceived low knowledge of the intended benefit of food RX to the patient, again, an area of improvement. And it is also evident that the pantry staff need to be better socialized to the objectives of the program so that they recognize that it's not just a food RX program, but to communicate that this is a health intervention and there be a robust nutrition education component tied to it as well. Overall, the pantry staff and volunteers were generally satisfied with the quantity of food provided by the food bank, but there was room for improvement in regards to the variety and quality, which largely could be due to the seasonal fluctuations in produce availability. And then this is a very important recurrent theme, that transportation was also identified again as a continued barrier to visiting the pantry for the patients. And so when we look at across all of these three groups, what we saw were these three recurring themes. Is one, there's a strong value proposition and support for the food RX program across all of these three stakeholder groups. But there's a tendency to view the program as food access program rather than a health intervention. And so there's a lot that could be done to bolster both the nutrition education, training, and communication in this regard. There's a perceived need for warm referral care coordination protocols, and so that there's a warm handoff between healthcare and social service agencies. Remember, these were 21 social healthcare agencies that participated in food RX, and so there needs to be more of a unified sort of an ecosystem effort to link multiple healthcare agencies to food pantries in a streamlined way. And then there's a strong recognition that the patient's barriers to addressing food insecurity may be related to food, but are also related to transportation that hinder participation in food RX. And so what might be the strategies that could be implemented across all of the partnerships? For its healthcare, perhaps there's partnerships with Metro that already exist, but could be more targeted to food RX participants, or could be, or there's communication that could be emphasized in regards to food RX participation that could bolster the transportation issue to further increase the participation and continued redemption of the prescriptions. So with that, I would like to invite my colleagues back to do a quick roundtable to bring the stakeholders, to discuss the various stakeholders. And we did a stakeholder mapping. We did an audience mapping of all of the stakeholder groups. So I'd like to invite my colleagues to speak to this, starting with, so I'll kick us off in terms of taking this work forward. So first, of course, the patient or the client is the most critical stakeholder. And so it is recommended that when it comes to the design of this sort of work, that patients be at the center of informing the framework and the design and the implementation of any type of food RX program. And what is critical in that, what we are understanding with this sort of work is that there are going to be multiple models in regards to food RX implementation. It's not going to be a one shoe fits all type of an approach. We are going to have multiple ways in which, for example, senior citizens may require a different type of a food RX model as compared to perhaps, high-risk pregnant moms who are, not allowed to get out of bed because of their condition. So we are going to need a menu of approaches and establish the evidence base around it to ultimately determine what's the best, depending on the segment of population that we're targeting. So we did a stakeholder audience mapping, and so we will go through some of this mapping and the recommendations across all of these stakeholder groups quickly, and then get to our Q&A session. So starting with, I'm going to hand it to Danielle, if you can talk to our first group of stakeholders, which is program implementers, such as yourself.
Yeah, so earlier we mentioned that the food RX model, similar to the one at Houston Food Bank, is unique in that it is scalable. Sorry, my light just went off, but we're going to keep going. And so scaling this type of model requires that program changes are made as a result of studies like this, and they provided actionable insights. And so going off of some of the recommendations Dr. Sharma just mentioned, we're looking to strengthen the existing footprint and expand the reach of our redemption sites or our markets and pantries to address some of the commonly cited challenges to program engagement, like transportation and the limited hours of operation at some of the pantries. Also, we would need to explore other innovative redemption models, maybe looking at partnerships with Metro, home delivery, things like that, that can be piloted. Second, we want to reframe food RX as a health intervention. It is critical that we address these types of perceptions of the program. And so we're looking to make sure that we're educating clinic staff that's delivering the intervention, as well as the individuals at the market. And we want to really emphasize nutrition education, because we can't just provide food and expect there to be a change in health outcome, right? We have to target the knowledge about those foods, how it goes back to the health condition, address skills on how to prepare them into nutritious meals, and then attitudes also about how these types of foods can be included to taste very good, and also be included as a variety of cultural ways of eating. We also want to implement some of those quality of life measures that can really convey a broader value of the program. So oftentimes patients may not be motivated by this program is going to help lower your A1C. That may not translate for them. And so really looking at, do you feel healthier as a result of this program? How's your fruit and vegetable intake changed? Maybe you're noticing a difference between some of the economic trade-offs that you make, so having to choose between rent or medication and food, things like that. And so at Houston Food Bank, we're looking to implement those measures in pre and post exposure to the intervention surveys. And then lastly, really looking to develop communication channels, so maybe text messaging systems, automated prompts that really target and keep enrollees engaged, to remind them to go back to their healthcare partner and redeem their prescription. Next slide. And then looking at advocates and community groups, again, we want to institutionalize the community perspective of this type of program. So that might mean that we're gathering and reflecting on community members specifically, and making sure that we're targeting their perceived challenges and how they'd like to see us mitigate some of those barriers. It's also important to collaborate with other stakeholders for long-term sustainability. We want to establish relationships and shared process across all of the sectors to support all aspects of food prescription programming and evaluation. And so a lot of implementers may not have these existing relationships, but it is important. They are integral to providing this type of program successfully. And then lastly, we want to support dissemination of research and findings. Not just in a general way, we want to make it broad to a wider audience. So using different techniques like common speak and sharing actual lived experiences of patients that have engaged with the program. And again, some of the market staff was voluntary, and so it may not always be the same person day to day. So these types of processes will help avoid any gaps in implementation and communication. And then I will pass it to Nalini.
Okay. We're very grateful to Houston Food Bank for having provided us this really valuable data to help us understand food programming. But if we want to institutionalize this, Sheila said one size fits all model is not going to work. So a lot of research needs to be done to see where to take this work, or if we want to expand the scope of this work. So one of the things that we felt very strongly was most research examines effects only over a 6-month period. So any additional research on this really needs to be looking at long-term effects that will also help any cost-benefit or cost-effectiveness analysis studies. Another area of research is that this whole idea of dissemination and implementation, Sheila referred to that when she talked about using models, but we do have to understand factors that affect program participation and think about alternative models of food provision. Again, they may need to be tailored. Another thing, and this may not just help Food RX, I think this whole idea of community organizations that are out there and working in the field, they don't have the time or the bandwidth to focus on data collection. But this happened to be an academic partnership that we happen to build up with Houston Food Bank. But this should generally be a model going forward. Community organizations and academic institutions like universities do need to build up partnerships for this work to really affect outcomes and design metrics and mapping. And finally, one more implication of our research that we thought is going to be really valuable going forward is implementing less burdensome measurement methods, not just for the outcomes. Reminding people to come back for the measurement is one part of it. The other part is we need to understand what exactly it is that helps people, that makes people go and redeem their prescriptions. We need to understand if consumption of healthy foods is one of the mediators. And then are there spending trade-offs? Are people actually benefiting more and spending more money on health when they had more money to spend thanks to their food costs being reduced? I think that's a subset of what we need to talk about. Sheila, on to you.
Sure. Thank you, Nalini. So I'm going to end with our healthcare payers and providers. And so we've talked about this, so I'm not going to spend a lot of time on it, but essentially there are many sort of improvements at one or opportunities that we have in regards to moving this work forward from an implementation perspective. We've talked about all of these in the previous slide. But I want to end on the funders and policymakers because a lot of this work is happens because of these two stakeholder groups, and it's really critical for us to inform future work in this space. One, we mentioned this before, but funders really should consider requiring partnership with academic or nonprofit research-focused agencies to build out some of these backbone data infrastructure necessary for ongoing monitoring and evaluation. And the reason for that is because if there is interest in really building out the argument for value-based care reimbursement, then we need to make this investment so that there is ongoing learning and monitoring and evaluation happening to inform the evidence base that's needed in this space. And not just on health outcomes, but also, of course, social, but also economic outcomes as well. Healthcare costs is a big piece of this that needs to be documented. Another piece is investment in foundational care coordination infrastructure support. How do we have to invert the burden on healthcare and social service agencies in regards to always, and the patient most importantly. And one of the ways that this could be done is by establishing ecosystems for care coordination so that these closed loop referrals can be facilitated. I mean, we live in a time where when you go to your healthcare provider, they can give you a prescription, they can send a prescription to a pharmacy of your choice, and you show up at the pharmacy and the prescription is filled out. And so there's no lag in regards to that there's no burden on you as a patient to redeem your prescription at any pharmacy of your choice. And so technology exists. How do we bring it to these frameworks to ensure closed loop referrals? Also looking at supporting research to understand, as Dr. Ranjit pointed out, the various challenges associated with redemption rates and also different strategies for food RX and making food more accessible for different segments of the population. And then last but not least, the good news is that there's mounting evidence nationwide on the effectiveness of these programs on various types of outcomes. But the work has to be regional as well. And so we're building out the regional data evidence in Texas to inform this work. And so legislative action to establish, MCO, social service agency type partnerships are needed to then bolster this evidence further to Medicare, Medicaid beneficiaries who are food insecure with chronic disease. So one of the things that we are launching is also an MCO payer think tank through a systems coalition here called the Health Equity Collective to inform so that we are not in the land of doing pilot projects until eternity. So with that, thank you again. I know we have just a couple of minutes to end, so I will we will have a final report, an implementation toolkit, and publications that will be available on this website. The implementation toolkit is really for all stakeholders to inform further work who are interested in further work in this area. So we'll have, for example, budget cost templates and all our evaluation frameworks and methods. And so these will all be publicly available as well. We are almost at time, but there's one question, and I want to direct that to Danielle before we run out of time. How was it determined? How was your formula determined to produce the 30 pounds of produce? And that amount, is it intended for the patient or the family as well? Can you talk a little bit about your formula? And can this be duplicated to other food banks? And we'll have to end on that because we've run out of time. Oh, you're muted.
The formula is intended specifically for the patient. And so the 30 pounds, while probably a lot of patients do have their families to consider, especially with food insecurity, that's probably not going to be enough to serve their entire family. And so again, it's not a full plate intervention. It is just to bring that additional produce to their plate. However, we've been in conversation about potentially changing that. I think it really kind of comes down to the community that you're serving and the needs that they've expressed. So different models could be tested there.
Thank you, Danielle, and thank you everybody for attending. We've run out of time. We appreciate you being here. Remember, the webinar will be archived on the Michael and Susan Dell Center website at msdcenter.org. Thank you again for joining us today. We will see you next time.